So the first speaker is an assistant professor at Harvard Medical School and a senior scientist at the Massachusetts General Hospital. His work, centered on health economics as well as decision science, helped inform several debated questions on the cost effectiveness of HCV as well as elimination. Along with WHO, he also developed the Hep C calculator, which allows policymakers from 28 countries to evaluate the cost effectiveness of treatment. His work also resonates outside of academia, notably being featured in the Wall Street Journal, Forbes, as well as NPR. Please join me in welcoming Jagpreet Chhatwal.
Good afternoon. So I'd like to thank the organizing committee for inviting me. It's a true honor to be here. I took a liberty to change the title, added cost in it, because when you talk about hepatitis C, we cannot ignore cost, and you will know by the end of the talk why this is important. So my disclosure, and I would like to acknowledge the funding sources and my wonderful colleagues, collaborators. You may know some of them. Okay, so let's start with the definition of hepatitis C eliminations. We just want to make sure that we all are on the same page. We are not talking about eradication of hepatitis C yet. We're talking about eliminating hepatitis C as a public health threat, which is a very specific definition defined by the World Health Organization, which says that by 2030, we should be able to reduce the incidence by 90%, mortality from Hep C by 65%. So these are the two targets defined by the WHO. And how can we achieve it? We should have the diagnosis rate reaching 90% and treating 80% of the eligible patients at least. So these are the definitions that we're talking about Hep C elimination. Unfortunately, I do not have any results for Canada, so I will stick with the United States results. So some of them can be applied to Canadian settings, others may not be. So let's start with the hepatitis C cascade of care. These are hot off the press results published this week showing how the cascade of care has changed over time. So if you look at the first set of bars, which shows in 2011, that's the pre-DA era, just before the DAs were launched, close to 4 million people had hepatitis C infection in the United States. And the cure rates were as low as 12%. Approximately 40% were unaware, and then 12% reached cure. If you look at the current setting, that's by the end of last year, we estimated around 2 million people still have chronic hepatitis C infection. Awareness rates have increased to 52%, and around 37% people have achieved cure. If we continue at the same pace, we do not change any setting, it's same status quo, the screenings and the treatment policies that we have in the US, by 2030, that's the elimination year, close to 2 million people will still have hepatitis C chronic infection. The awareness rates would be around 50%, and around 50% people would have, the awareness rate would be 62%, and close to 50% people would have achieved cure by that time. So clearly very far away from the elimination targets defined by the WHO. So this is the overall picture. But if you look at things under the hood by different subpopulations, Medicare, to contrast the results, which is Medicare, anyone above the age of 65, almost everybody above the age of 65 has Medicare in the US, so you can compare with the Canadian setting, almost universal access to insurance coverage by the government. So one key thing about Medicare is that the population is aging. They would be transitioning to Medicare. So you see that there is a jump in the number of people who would be having Hep C either cured or uncured over time. And if you look at 2030, that's the elimination year. We expect close to 90% people would have achieved cure by 2030, which is a great news, which seems that in this subpopulation, Hep C elimination is clearly feasible. To contrast these results, if you look at prisons population, this is which has a high burden, like close to 1.25 million people in the US in prisons have hepatitis C. And by 2030, if we continue at the pace we have seen in the current policies and screening rates in US prisons, we see that by 2030, only 17% of people would have achieved cure by that time. Things look quite different within states, and this map shows that what's the prevalence of hepatitis C in prisons by different states. You see that some of the bordering states to Canada, Maine, North Dakota, Oregon, they have high prevalence. More than 20% of people in prisons have hepatitis C antibodies. And approximately 75% or maybe a little less than that would still be viremic. The access remains poor and then by states. And you see that many states have less than 1% of Hep C people treated within their in state prisons. And another situation that's worsening in the US and to some extent in Canada is the rising Hep C incidence. So these are the data from the CDC show that in the last 5 years, incidence has increased 3 times, mainly driven by the opioid epidemic. So the question is Hep C elimination feasible in the United States and in which populations? So if we come back to this cascade of care, so from this mathematical model, we projected that if we change the screening policy to universal instead of what we have right now is the birth cohort and risk-based screening, plus no treatment restrictions, plus magically the Hep C incidence decreases to the 2011 levels. We don't know yet how it's feasible, but let's assume that it's possible. Can we achieve Hep C elimination by that time? Clearly that by 2030, still the cure rates would be 62%, which is substantially below the 80% target we have from the WHO. So this clearly shows that even if we do what we have within our capacity, within our system, still elimination is not feasible. And the key ingredient here is the screening rate. So it's in this assumption we use 9% screening rate, which is the maximum we have seen in the birth cohort screening. So it's very difficult to believe that the screening rate will go up unless we add additional interventions. So what about the costs? So we cannot ignore cost. So look at the perspective of cost, DAA cost from pharma versus payers. So this left figure shows that from pharma's perspective that is showing the cost of peg interferon ribavirin, the first generation DAAs, and then the soft ledespesivir, the oral DAAs when they became available, close to $84,000. So clearly the costs started rising, but if you look at the cost per SVR, that continued to decrease over time. But from the payer's perspective, many of you have seen this figure. It's $1,000 a pill. That was raised. So that's clearly from the payer's perspective that got their attention. Is it affordable or can we afford this drug at this price? And this is a public perspective, very interesting figure from the NPR showing $1,000 bill. And the picture is John Martins, who was the CEO of Gilead Sciences at that time. So the question is this $1,000 pill justified? And this was a question that was asked in 2015 when the drugs were launched several times by media. So how do you really answer this question if the price is right or not? So let me go back to some basics of cost effectiveness. So what do we mean by if treatment is cost effective or not? When we say something is cost effective, it doesn't mean it's cost saving. It does not necessarily mean it's affordable. What cost effectiveness simply implies is that we are willing to spend additional money to gain additional health benefits. The key part is we are willing to spend that money, and how we define that willingness can vary from one setting to another. And there is a related concept of cost saving, which implies that we're willing, so we gain health benefits by implementing some intervention, and at the same time, we save money. So it is a slightly related concept, but it's not same as a cost effectiveness. So coming back to this question, what is the value of Hep C treatment, or is Hep C treatment cost effective or not? So two things, I've put some examples in the context to answer this question, 2 other diseases before we look at the answer. And the 2 questions we ask, one is what is the lifetime cost of treatment for this whatever intervention we're looking at? The second is how much would it cost to gain 1 additional quality adjusted life year or 1 additional life year, whatever metric we use? So that second question really tells us if something is cost effective or not. So let's look at the example from HIV. So the lifetime cost of HIV treatment is more than $300,000. And if you look at another liver disease, primary biliary cholangitis, the treatment cost, the listed price is close to $900,000 in the US. It could vary from in other countries. And in hepatitis C, we know that at current prices have come down to below $30,000. That's a lifetime cost. It's one time, 12 weeks treatment for majority of patients. So that's the cost we're looking at. Now, how much would it cost to gain one additional life year with HIV? It's less than $30,000. And in the US, if we use a metric of 100,000 as our threshold, anything below that, we can simplify, say that it's cost effective. If something costs more than $100,000 to gain one additional life year, we can say that it's not cost effective. This $100,000 threshold can be, one can argue if this is right or not, but let's assume that that's the threshold. For primary biliary cholangitis, this number comes down to $190,000 to gain one additional life year. So using that metric, we'll conclude something is not cost effective. For hepatitis C, I'll pause here and see if anyone knows the answer. So I've asked this question multiple meetings in the last 2 years. Only one person has given me the right answer. It's a large room, so I would not ask particularly, but you may be thinking in your heads, actually it's negative. So what it means is that it's cost saving. So if we treat somebody, it's not we just adding life years, we're also saving costs. So once we show that HCV treatment is cost effective, then the math any health economist can tell you is very simple. The more we treat, the more we save. Then if we treat 100 people, we may say X. If we treat 1,000 people, we save 10 times X, so whatever that X is. So where's the problem? Before going to the problem, so this is not coming from like 1 or 2 studies. Actually, this is like we did a systematic review of 89 studies, the ICERs or the analysis that show that this, in fact, is shown by most of the studies. And at that time, if we use $60,000 as our price for DAAs, which we now know is lower, 71% studies showed it's cost saving, 22 said it's cost effective. But if we look at the prices close to $30,000, almost 90% studies would conclude treatment is cost saving. So how do we assess these? We use mathematical models. That's the most common way. No, indeed, these models are complex. So what we did was with the World Health Organization, we developed this interactive website, Hep C Calculator, which has data from 28 countries. We'll be expanding that soon, which allow users to go and play with some inputs, country-specific inputs, and look at if treatment is cost-saving or cost-effective in that country, at what price. And this has been used for price negotiations by multiple countries. Okay, so where's the problem with Hep C elimination or cost effectiveness? So this figure explains to some extent the problem is in the budget. So what we see is the over time, what is the cost of we spending on hepatitis C? The blue one is the cost of disease management. Somebody develops liver cancer, liver transplant. That's the cost somebody would have to pay. The yellow one is the cost of treatment, and the orange one, which you can hardly see, is the cost of screening in the U.S. So this shows that in 2000, from 11, when the first generation DAAs were approved, that's the price of treatment increased because people got treatment with more expensive drugs. And in 2014, the price jumped to close to $20 billion on treatment, and 17 billion of them were on treatment. And why this jump? Because of the launch of oral DAAs. Many people who were warehoused earlier now came forward with treatment. Also, we have seen the screening updates happening before the launch of DAAs. The oral DAAs, the CDC recommending baby boomers to get one-time screening. Plus, there was an insurance expansion from Affordable Care Act. So all these factors contributed to more people coming in access to who had now access to providers and Hep C treatment. With competition, prices came down, also the spending on treatment. And by 2020, we expect that if we do not change any settings or any screening policies, the majority of patients who are aware of the disease would receive treatment by that time, and the spending on treatments would be lower, assuming the prices at that time, this is an old study, which prices have come down, so this figure probably has shrinked a little bit. So though in the US we assume that we have unlimited resources, but when it comes to hepatitis C, this is not the case. If you look at from how much would we have to spend to eliminate hepatitis C, or let's say to make it a rare disease, from this mathematical model, this number comes to close to $100 billion, which is no doubt a large number. But if you look things in the context of HIV, and 5 year spending of HIV is more than $150 billion now. So that gives us some perspective. Is it possible? Is it feasible or not? And also to make sure that it's, in fact, if you remember that treating Hep C is cost saving, so that can also give us an idea of cost savings that will eventually happen. They may not come right away, but later on. Okay, so let me shift gears from US to Pakistan, which provides a contrast. It has a high prevalence. More than 8 million people have hepatitis C in Pakistan. But the good thing about Pakistan is it has one of the cheapest generic DAAs, which cost close to $60 for 12 weeks of treatment. So the question is Hep C elimination feasible in a country like Pakistan? So this is the trends showing if we continue at the status quo, this figure shows close to 8 million people will have Hep C, and numbers are not going to change much until 2030. And the problem, and another problem in Pakistan is the awareness rate is very low, just approximately 5% people know they have Hep C. So we published a study this week, and Naveed Janju was also a co-author on this, who's been working with Pakistan, and we looked at in what setting, what would it take to eliminate hepatitis C in Pakistan. So this shows that we need to diagnose at least 900,000 people per year, which means for that we would have to screen close to 25 million people every year in Pakistan. And we have to treat close to approximately 700,000 people every year to eliminate hepatitis C by 2030. So these numbers provide as a guidepost to policymakers on what needs to be done. Now, is it feasible practically? Perhaps yes. We can look at Egypt as an example, who has been very good with scaling up screening and treatment. And if we are able to do that, this is how the prevalence will look like over time. A number of people with Hep C decreasing, and number of non-viremic people would be increasing. So looking closely at the cost landscape, though the generics are very cheap, $60, but the cost of testing remains high. In fact, the NAT tests more than the cost of NAT is more than the cost of DA treatment, and there are other costs, test costs also very high. So the question was then, what would be the cost of scaling up treatment in Pakistan or screening in Pakistan? And then we looked at different testing algorithms that are being considered in Pakistan or being recommended by the WHO. This figure shows that, to give an example, this is the current standard laboratory-based screening test, followed by NAT for viremia detection and NAT for assessment of treatment response. And we looked at 6 other treatment algorithms, which could be either point of care for screening, or for viremia could be core antigen, could be gene expert, combinations of different tests, etc. And then we look at the cost of scaling up screening in Pakistan. The blue line shows the status quo, and the gray line shows the cost of scaling up treatment and screening to eliminate hepatitis C by 2030. So we see that clearly there is an initial investment needed. Eventually, the cost will go down with that. The same treatment, the testing algorithm. But if we add other testing algorithms that I just showed in the table, the costs keep coming down. And finally, if you look at this T4, which has the lowest cost of elimination, T4 is its point of care testing for screening, and a gene expert for assessment of treatment response and viremia. And T5, which is also very close, is a combination of core antigen and NAT for assessment of viremia. Okay, so what is the cumulative cost? The left figure shows how much would it have to would be the cost on Hep C treatment spending if we do not change anything, and the right ones show the cost of elimination. And the light blue color shows the cost of disease management, like HCC, liver transplant, etc. And on the right side, you see that the cost has gone down because naturally we have treated more people, but the other cost we have added. The red one is the cost of screening, and the dark blue is the cost of post-treatment testing. So clearly these, depending on what testing algorithm we use, the cost can vary hugely. And for many cases, the cost of elimination can eventually result in cost savings. It shows that the total cost will be lower than the status quo. And this is that T4 algorithm, which I showed, the point of care testing for test for antibody screening, detection of viremia, and treatment response. So moving forward, so what we have seen so far that we need to scale up screening, we need investments, but that leads to another question. Can we afford that? How do we get money for that? So this is an important question from public health perspective. We need innovative financing solutions, approaches which have not been done earlier in the hepatitis C. Clearly, the status quo is not working. So there are certain characteristics to keep in mind for hepatitis C financing. One is that we need investments now, but the returns will come later. Because hep C is a slow progressive disease, whatever the benefits of preventing somebody from transplants or liver cancer will be like down the road, 20 years, 30 years down later. So in the US, so these are like two states have agreed to implement this innovative subscription-based model, popularly known as Netflix model. What it means is that the payer and the pharmaceutical company sign an agreement for a fixed term budget, and then in return, they may have access to unlimited treatment to some sense. So it's a fixed budget. It's a win-win situation. Payers know what their budget would be for the next 5 years. For pharmaceuticals, know what their revenue would be for the next 5 years. And anyone who has hep C knows hep C can get treatment, and then there is no restriction. And this model has been implemented successfully in Australia and also in England last month, or within last couple of weeks, announced that they would be moving forward with such innovative mechanism. Another less discussed mechanism could be financial bonds. As many of you may know, that the idea of bonds is to transfer the risk associated with long-term spending commitments from government or payer to investors. And we have used some examples of bonds here, like commercial bonds are most popular, but there are vaccine bonds which have been used. There's like social impact bonds can also be used to raise money for hep C investment that can lead to elimination. So key points, my last slide. So the message is that hep C elimination will require substantial scaling up of testing and treatment both. We need innovative testing approaches to lower the cost of diagnosis and scaling up the screening. We also need innovative funding mechanisms to raise the investment needed to eliminate hepatitis C. And finally, we should remember that money spent on hepatitis C provides a good return on investment, and both in terms of life years saved, deaths prevented, as well as the economic savings. So with that, I would like to thank you all for your attention.